rectum. Rectal disease, there is benign disease and there is malignant rectal disease, that's to say rectal carcinoma. You have to know the anatomy and the blood supply, venous drainage, and lymphatic drainage to know the signs and symptoms of rectal disease, and to how to examine the rectum, investigation of rectal disease. And rectal injuries, diagnosis, and diagnosis and management of rectal disease. Also, other benign like rectal polyp, foreign body in the rectum, and benign tumor and malignant tumors of the rectum. Surgical anatomy of the rectum, it starts from rectosigmoid junction, which lie opposite to the sacral promontory, to the anorectal junction. From rectosigmoid junction to rectoanal junction. Here the anorectal ring about 120 degree created by puborectalis muscle. The rectum has 3 lateral curves, upper and lower are convex to the right and the middle convex to the left. Wider part of the rectum called umbrella of the rectum, which lie below. Adult rectum is about 18 to 20 centimeter in length. It divided 3 equal parts. The upper third, which is mobile and has peritoneal coat, except near the midline, the middle third, where the peritoneum covers only the anterior and part of the lateral surfaces. Middle third, which is the widest part of the rectum, and lower third, which lie within the muscular floor of the pelvis. يعني الركتم هو 3 parts, upper third covered by peritoneum, middle third covered anteriorly, and lower third intramuscular, devoid of peritoneum. The lower part of the rectum is separated by facial condensation, the non-velar fascia, from the prostate in front and behind by wide layer fascia from the coccyx and last 2 sacral vertebrae. These 2 fascia has 2 surgical importance, barrier to malignant penetration and vulnerable guide at operation. طبعا هاي بالميل انه related to the prostate. بالفيميل طبعا relation different, انه راح يكون عندنا anterior to the rectum is the cervix and the uterus. This is in female, in male is the prostate. Blood supply, superior rectal artery, it is continuation of inferior mesenteric artery divided to right and anterior branches, and middle rectal branch from the internal iliac artery. Middle rectal artery, branch of internal iliac artery, and inferior rectal artery, which is a branch from inferior internal pudendal artery. Blood supply of the rectum. Venous drainage, superior hemorrhoidal vein drain the upper half of the canal above the dentate line. It becomes superior rectal vein, then inferior mesenteric vein, which are drained to the splenic vein to form splenic vein, way superior mesenteric vein to form the portal vein. Middle rectal vein, small and unimportant surgically. Channels, unless the normal pathways are blocked. and lymphatic drainage, usually upward, at limited extent downward and laterally. But if this way blocked by malignant tumor, the way change the side wall of the pelvis and even to inguinal region. Superior rectal lymph nodes, important group of lymph nodes located on the back of umbrella above levator ani muscle, lymph node of Girote, and middle rectal lymph nodes lie close to middle rectal artery, يعني corresponding to the arteries. The lymphatics are corresponding to the arteries. Clinical feature of rectal disease, bleeding, important. Bleeding per rectum must see color and amount, dripping or sealing, pre or after defecation associated with pain or not. Altered bowel habit and discharge as mucus or pus and tenesmus, feeling of defecation but nothing happened, prolapse, pruritus, and loss of weight. And examination of the rectum includes visual inspection, يعني by inspection of the perineum, digital examination, proctoscopy, sigmoidoscopy, whether rigid or flexible. Position of the digital rectal examination, either lateral sims or knee elbow position. And rectal injuries, regarding rectal injuries, rectum and anal canal may be injured by many ways. All uncommon by falling in a sitting posture on a sharp object or by fetal head during delivery, by serious sexual assault, يعني high causes of major rectal injuries. And diagnosis from history, most important question, is the patient pass urine after accident to exclude urethral or bladder injury. Then examine anus by inspection, per rectal examination, to see if blood in the finger or palpate any defect in the continuity of the wall of the rectum. Proctoscopy and or sigmoidoscopy. There is no rigidity of the abdomen, but if there is rigid abdomen, usually patients need early explorative laparotomy. And management of rectal injuries after patient has been anesthetized. The rectum is examined with the finger and speculum, depend on the site of rectal injury, whether above or below the pelvic floor. In both conditions, lower laparotomy was done. Cases above the pelvis, pelvic floor, proximal colostomy with suturing of injured site. يعني إذا الانجري in both conditions, lower laparotomy done. In cases above the pelvic floor, you have to suture the injury and we have to do a proximal colostomy, defunctioning colostomy, in order to let healing as early as possible. It is temporary, 2 to 3 months. If injury below pelvic floor, also proximal colostomy with wide drainage from the belows. From below is indicated if injured large area, resection of part of the rectum is in such circumstances, Hartmann procedure is indicated with preservation of anal sphincter with covering of antibiotic for both aerobes and anaerobic bacteria. It is important when there's large segment of the rectum or there is massive injury of the rectum also, you have to do Hartmann procedure with the preservation of anal sphincter under cover of antibiotic against aerobes and anaerobes. At the end of rectal injuries, we start with rectal prolapse. This may be partial or rectal prolapse. And partial prolapse is confined to the mucosa, which prolapse an inch or 2 from anal verge. Palpation of a prolapsed between the finger and the thumb reveals that there is no muscular wall within it, only double layer of a membrane. It may occur in extreme of life in children 1 to 3 years and in elderly people, and causes an infant undeveloped sacral curve, underdeveloped or undeveloped sacral curve, direct downward course of the rectum, diminished in the amount of fat in the ischiorectal fossa, fibrocystic disease, and maldevelopment of the pelvis. In adult, third-degree hemorrhoid straining from urethral structure. In female, a torn perineum predisposed to this condition, and may follow an operation for fistula in ano, where a large portion of the muscles are removed. Treatment of these babies require nothing more than reassurance of the parent that the condition is self-limiting or self-curing. Digital reposition with tissue paper clinics نستخدم by index finger and submucous injection if digital reposition failed. Submucous injection of phenol in almond oil if digital reposition failed. In adults, submucous injection, excision of prolapsed mucosa. And complete prolapse is less common than partial, involve all layers of the rectal wall, more than 4 centimeters, and commonly as much as 10 to 15 centimeters in length, usually occur in elderly women, 6 times more common than male. In women, usually associated with the prolapse uterus, it is uncommon in children. Apart from the discomfort of the prolapse, there is associated incontinence due to stretching of the sphincter and mucus discharge from the prolapsed mucosa surface. And the differential diagnosis, ileocecal intussusception, children, and rectosigmoid intussusception, adult. And the treatment of partial prolapse in adult comprise excision of the redundant mucosa, excision of redundant mucosa, or a submucosal phenol or submucosal phenol in almond oil injection in order to produce sclerosis. Many methods have been described for dealing with complete prolapse and perineal approach. Tertiary wire operation for perineal approach, treatment of prolapse, tertiary wire or tertiary procedure where a wire or nylon suture passed around the anal orifice to narrow it and keep the prolapse reduced. Today, 2 procedures are commonly performed. The first is fixation of the rectum in the pelvis by abdominal operations such as wrapping the mobilized rectum in polyvinyl sponge, which produces a brisk fibrous reaction, welding the rectum to the pelvic tissue. And the second is Dermis procedure, involve a less traumatic perineal approach with excision of the mucosa and bunching of the bowel muscle to form a Duffnet-like ring, which holds the rectum in the pelvis rather as a ring. Pessary may control vaginal prolapse. Abdominal approach, Wells procedure, يعني عندنا perineal approach وعندنا اللي هو abdominal approach. Wells operation. In this operation, the rectum is fixed firmly to the sacrum by polypropylene mesh inserted between them. And Rubinstein operation. This operation, the rectosigmoidal junction edged up by Teflon. And regarding solitary rectal ulcer, it is an ulcer in the interior wall of the rectum it must be differentiated from rectal carcinoma and inflammatory bowel disease. Patient complain from pain and discharge. Rectal prolapse, the rectum and sigmoid colon are most frequent site for polyps in the gastrointestinal tract. Rectal polyps, the rectum and sigmoid colon are the most frequent site for polyps in gastrointestinal tract. Polyps have tendency for malignancy, يعني malignant condition, especially if polyps more than 1 centimeter in diameter or show obvious sign of increase in size, or it is sessile rather than pedunculated. This carries risk of malignancy. And types of polyps, juvenile polyp, it is bright red blistering pedunculated. This is more common in children. Metaplastic polyps, small pinkish sessile polyps, frequently multiple. They are harmless. Inflammatory polyps or pseudopolyps due to edema of mucous membrane, usually associated with inflammatory bowel disease, and adenomatous polyp. They are frond-like appearance, very large size. They have tendency to become malignant. Rarely profuse mucus discharge from the tumor rich with potassium and may cause electrolyte disturbances. All neoplastic polyps can be solitary or multiple, and familial adenomatous polyposis FAP, autosomal dominant inherited disease characterized by multiple rectal and colon polyps around puberty and average age 25 years, and onset of colon cancer is 40 to 45 years. And types of treatment after diagnosis: total colectomy with mucosal proctectomy, total colectomy with ونحافظ على الركتم يعني بس mucosal proctectomy يعني نشيل فقط الميوكوزا. Ilioanal pull-through anastomosis with the creation of a reservoir pouch, creation of reservoir pouch. And other operation of treatments are subtotal colectomy with iliorectal anastomosis for patients with very few rectal polyps, or ileostomy with total abdominal colectomy. إذن بهاي المحاضرة كملنا rectum, anatomy, injuries, abnormalities, rectal prolapse, foreign bodies of the rectum, and rectal polyps. And we start with rectal tumors, could be benign or malignant. Tumors, pathologically benign, like adenoma, papilloma, lipoma, endometrioma, and malignant tumor. Primary adenocarcinoma, malignant tumor of the rectum. Primary, like adenocarcinoma, which is common as squamous cell carcinoma of the lower anal canal, melanoma, malignant melanoma, and lymphoma. And secondary invasion from prostate, uterus, pelvic peritoneum, deposition, pelvic peritoneal deposition. Okay, that's enough in this lecture. Next lecture, to discuss the malignant tumors of the rectum, especially carcinoma of the rectum. Thank you very much.